Hello everyone, welcome to day 8 of our challenges series. Today we will be talking about orthopedics part 1 till page number 129. We will try to complete the initial basics along with the upper limb, upper extremity pathologies in this section. Okay, starting with the first part, which is bone formation. You need to remember two types: enchondral versus membranous. Enchondral happens in axial bones and appendicular skeleton, and also in the base of skull, where you have cartilage modeling of the bone, first by chondrocytes, osteoclasts and osteoblasts, later replaced with woven bone, and then lamellar bone. This is defective in achondroplasia. However, in membranous ossification, the bones of calvaria, most important thing will be the facial and clavicle bones. Here, woven bone directly forms without any cartilage, later remodeled into lamellar bone. Some important cells you need to remember being osteoblasts, clasts, and sites. So, osteoblasts, you need to remember they build bone, B for building. They secrete collagen and catalyze mineralization in alkaline environment via ALP. Okay. The important thing is you need to remember how it works. PTH will stimulate rank ligand. Estrogen stimulates osteoprotein, and cortisol suppresses osteoblast maturation from rank ligand. So this activity of osteoblasts is measured by ALP. And there are other markers also, osteocalcin and propeptides of type 1 collagen, N-terminal and C-terminal ones. Osteoclasts, you need to remember, it dissolves bone. Here it builds bone. Clasts will dissolve bone by secreting H plus and collagenases. This was an alkaline environment. So since it secretes H plus and collagenase, it is in acidic environment. Osteoblasts are from mesenchymal stem cells in periosteum. Osteoclasts are from fusion of macrophages or monocyte precursors. Some important stimulants here are MCSF, rank ligand, IL-1 and PTH. However, the ones which were helpful in stimulating osteoblasts are inhibiting osteoclasts. These are osteoprotein and estrogen. Then you have your osteocytes, which are stellate-shaped cells left behind in bony matrix during bone formation. So these inhibit lacunae. They are involved in routine turnover of bony matrix. So FGF23 is one thing which is associated with osteocytes. Then you have your key substances, which I have almost talked about: PTH, estrogen, osteocalcin, sclerostin, and FGF23. Go through them once. FGF23 is particularly important because its unregulated secretion by tumors causes hypophosphatemia and osteomalacia. Okay. Other than that, you need to remember the markers of the bone. Bone formation markers are your all osteoblastic markers, which is bone specific ALP, osteocalcin, serum procollagen type 1. Bone resorption markers are N-telopeptide, C-telopeptide, S-trap, hydroxyproline, and pyridonylin. Okay. Then constituents of bone, you just remember 65 to 75% of the bone is mainly inorganic, 30 to 35% is organic. Organic bone I had already told you in biochemistry, bone is BONE, which is type 1 collagen. Okay. This is the organic component. Then there are non-collagenous proteins also, osteocalcin being the most important one. Then we have your types of epiphysis: pressure, traction, aberrant and atavistic. One important thing to remember will be aberrant epiphysis. This is an anatomical anomaly. So X-ray ectopic epiphysis will be the ones which come under aberrant epiphysis. They include head of first metacarpal and base of the rest metacarpals. Okay. Atavistic are phylogenetically independent, but they have they can function independently, but they become fused. So one important thing to remember in atavistic is your coracoid process. Then physis, what you'll remember is the layers: resting zone, proliferative zone, match RPMZ. Resting, proliferative, mature, and provisional calcification zone ZC. Okay, this provisional calcification zone is affected in rickets. Scurvy, you have your proliferative zone affected. Then you need to remember the classification for the fractures. So the important two classification is the Salter-Harris for unfused bones, pediatric bones, where you have type 1 to 5 Salter, which mnemonic I have already given you. Then you have Gustello-Anderson for your trauma, where the grading of the wound happens. So just remember the important cutoff for each of them will be 1 centimeter, less than 1 centimeter grade 1, grade 2 will be more than 1 centimeter wound with soft tissue damage. Grade 3 will also have a degree of additional damage, that is comminution, contamination, or segmental fractures. I have already given that, just go through them once. Then you have the stages of bone union. You have 5 important stages: hematoma, granulation tissue, callus, remodeling, and modeling. Okay, remodeling happens after 1 to 2 years. Then you have less than 7 days will be hematoma, 2 to 3 weeks will be your granulation tissue, and 4 to 12 weeks will be your callus formation. Then you need to remember the healing of fractures, primary versus secondary healing. In primary healing, you don't have any callus formation which is present in secondary healing. That is why plating acts without any callus formation comes under primary healing. Nailing and casting acts through callus formation comes under secondary healing. Then you have your FOOSH, fall on outstretched hand, the fractures of importance, most common being callus. Another two important things which they might give with FOOSH will be supracondylar fracture and your scaphoid fracture. Then the fractures of necessity is given by the mnemonic Glonan, go through that once. These require surgical treatment, you can't just do conservative management for this. Then you have how to immobilize fractures. There are certain important ones: strapping, sling. Strapping, you remember buddy strapping for the phalangeal fracture, slings, the triangular sling for clavicular fracture. Then cast immobilization, which is the most common one, we use POP cast. Then we also use fiberglass cast, just remember the IBQ associated with that. Then you have a spica, where the part of trunk is also involved. Hip spica is used, shoulder spica is used. Then you have your functional bracing, so that the joints are not included, patient can do his daily activities, commonly used for stable fractures of tibia and humerus. Then you have your splints and traction. So I have given some important images for splints and for casts. Some of the most important ones I would like you to remember are the cock-up for radial nerves, knuckle bender for ulnar nerve palsy, aeroplane splint for brachial plexus injury, Bowler Braun for fracture of femur. Then for casts, you need to remember two important ones: the handshake cast for fracture lower limb radius, then the hanging cast or U slab for fracture shaft of femur. Then there is also one more important one, which is glass holding cast for scaphoid fracture. Then you have your types of traction: fixed versus sliding traction. Fixed traction, the Thomas splint fixed traction. Sliding traction, where the weight of the body acts as counter traction, is given for pelvic fractures. Then you have skin traction versus skeletal traction. So when an adhesive tape is applied on skin, then it will be skin traction, transmitted from skin to bone. Skeletal traction, you will directly apply it on bone through K-wire or Steinmann pin. Then you have the types of named ones. Two important ones I would like you to remember is your already I have discussed about K-wire and Steinmann pin for skeletal traction. Other important ones you need to remember are your Dunlop and Smith for supracondylar or condylar fracture of humerus, and then you have your Denham pin for osteoporotic or cancellous bone. Okay, that's all from the tractions which we have used. Then we will go to operative methods for immobilization and treatment. So internal fixation, external fixation, tension band wiring. So internal fixation, you will use screws, pins, plates, wires, intramedullary nails. So all the fractures that cannot be reduced except by operations with the fractures of necessity come under this, then the unstable ones and the fractures prone to non-union. So these are some indications you need to remember. Then external fixation will be the ones where you use ring fixators or pin fixators. Here it is done when the fractures are associated with severe soft tissue damage and associated with nerve or vessel damage. Okay, and unstable fractures. Tension band wiring, remember, it is now commonly as especially for patella fracture. Other important ones where it is used is the olecranon and the fifth metatarsal fracture. Here the tensile force is converted into compressive force which facilitates healing. Then upper extremity wise, what you need to remember is the muscles which cause abduction, adduction, internal rotation and external rotation which I have given. Then remember the dislocation, shoulder dislocation types, anterior, inferior and posterior. In shoulder dislocation, anterior, what you will remember? Is your tests. One important test I would like you to remember is your Callaway test. Then for reduction methods, you have your Cocos maneuver which involves steam, that is traction, external rotation, then and medial rotation. Okay. Then you have your Stimson's maneuver which is no longer used, which is a gravity assisted maneuver. Then you have your inferior and posterior dislocations. In inferior, you need to remember one important thing. They will give a history of, in posterior they will give a history of lightning or electric shock, and the radiologically you will have your electric bulb sign or empty glenoid sign in posterior. However, in inferior you will see a person coming with salute position, which is due to hyperlaxity or laxatio erecta. This occurs when a patient has had an hyperabduction force that has caused impingement of neck of humerus. Next, what important stuffs you will remember is the recurrent shoulder dislocation. Anterior recurrent shoulder dislocation happens due to Bankard's and your Hill Sachs. However, when there is a recurrent posterior dislocation, you need to remember there is something called reverse Hill Sachs. Then there is some Matson's classification which is not that important in the shoulder stability test, which is also not that important. Surgeries, you just remember the names: Bankard's, Putty-Platt and Bristol-Attarget. Some eponyms I have given. Also some important points about each of the fracture and how to treat them depending on displacement is present, is it open or not a open fracture, closed fracture. So remember, among all this, the most important two which you should remember is your supracondylar one and your radioulnar fractures. These two are must knows. Then you can remember the classic complications for each of them. For scaphoid, everyone should remember that it will always it is prone to cause avascular necrosis. You should just remember this should be in your reflex. Malunion and non-union, we have dealt with it separately in further classic complications of fractures, but for scaphoid there is avian, that you have to remember. Then for supracondylar, you have to remember your Gatland classification, which was recently asked also. Just remember the name and a bit diagrammatic memory for the classification of types. Also, cubitus valgus is seen with lateral condylar fracture, that also you need to remember. Then the eponyms, Most important ones are your um, Montague and Galeazzi. I think you will remember by the mnemonic which you already know. Then you have Coles. Then Bartons and Schauffers are also important. Both of them are intra-articular fractures, where Coles being extra-articular. And next you need to remember Coles versus Smiths. You have different casts. The position of cast in Coles is known by the famous mnemonic propaganda, where pro means pronation, PAG means palmar angulation, UN means ulnar deviation, and UNDA means ulnar deviation. And the cast here is below elbow cast in handshake position. In Smiths, you have an above elbow cast, while the position of cast here will be SLIP. Okay, where S is supination, L is lateral tilt or shift, then I is impaction, which is proximal shift, then P is posterior displacement or tilt. Then you need to remember Bennett's versus Rolando's. These are some important confuses. Just go through them once. In Bennett's and in Ronaldo's, you need to remember that Bennett's will be an oblique intra-articular fracture of base of first metacarpal. So Bennett will be oblique intra-articular base of first metacarpal. Rolando's is also base of first metacarpal, but it is VY shaped. It may be intra or extra, it is a bit controversial, but remember it is comminuted VY type, unlike Bennett, which is oblique. Okay. Treatment, however, changes. For Bennett, it is always ORIF. That is what you need to remember. That's all from today's session. We'll continue the rest of the orthopedics in next session. Very quickly, go through the images which we have described in the notes. These are very important images, and most of the ortho questions will be IBQs always. Okay, remember this, and all of us. Hope you are all keeping up with the time. We'll meet again for the next session.